Thank you. Can everybody hear me okay? The microphone is a little bit further away from me. Can you hear me? It's okay, yes? Way at the back in the cheap seats? Yeah, you know what they say about the after lunch or after dinner person, right? Either it's the one you can sleep through or the one that has to entertain. So hopefully we'll do the latter, not the former. That was a long introduction, and thankfully that means I can actually skip through a few of my first slides here. Yeah, part of the work that I do, or a lot of the work that I do these days, is translating the knowledge of about 17 years of trauma practice into different professions, different environments, whether it's education or medicine or those kinds of things. So hopefully what I can do today is just try to give you a few tidbits of information. We had a great presentation by Diane going into the research and the clinical sides of things. Really what I'm going to try to do is be very pragmatic about my practice, the kinds of things that I would suggest. If you have questions or curiosity, hopefully I have time at the end here. There's my statement of conflict of interest. I have none, and I'm only funded by the Social Sciences and Humanities Research Council for my research on military transition. Here's just a brief overview of what I'm going to try and get through. If you can take notes, I'll be testing on this later. Just joking. This will all be made available, so please don't feel the need to take notes. You can get a hold of it. I'm going to talk a bit about simple and complex trauma. I'm going to introduce, people have alluded to it throughout the night, but the Tri-Phasic model of trauma treatment, which some of you may know, some of you may not. I'm going to look at some of the tools for screening for trauma, and again, just pragmatic tools that you might want to use in your practice and consider just right up front. In working with Linda and the folks, it's always interesting when we compare what psychologists by nature do and then what family docs don't by nature do, like screening for suicide. We screen for suicide with every single person who comes through our door, and yet that doesn't necessarily become a standard practice for all family docs. I was like, oh, that's very interesting. So same thing with trauma, that kind of stuff. You know, typically we're asking for adverse life events in early childhood, et cetera, but that may not be standard practice. Whether it needs to be or not is debatable, but I always find it interesting. So relevant to the Tri-Phasic model are things like safety stabilization. How do you assess that? How do you help resource people? I use a 4-quadrant model, which I'll introduce, and you may or may not have heard the window of tolerance metaphor by Pat Ogden. I'm going to introduce that. I find it a really helpful metaphor, especially if you're thinking about people who are in your office. When I developed the behavioral medicine program, which became the micro skills coaching program at St. Paul's, one of the big ones was, which I know isn't relevant for anybody in this room, is the never-ending patient. The 10-minute session that becomes an hour and a half, and so oftentimes, if that is somebody who's been traumatized, of course, we're compassionate. We want to make sure that we don't leave them hanging, and yet we get behind and get stressed out. So we'll talk a little bit about the window of tolerance, and I'm going to talk just a bit about self-regulation and addictions. I'm not an addiction specialist. I tend to refer out for that stuff. Folks at Island Health can certainly help you more with the clinical side of that, but I will kind of integrate some of that stuff around self-regulation. There's going to be a prize at the end if anybody can guess what CVC stands for. So stay tuned. And then just some very, very pragmatic things about things like office setup and what I call my no surprises policies. So with that in mind, I don't need to go over this again. One of the things that wasn't mentioned, just my research into military and civilian transition, which is ongoing. Also, when I started getting into the field of trauma work, there were no courses at the graduate level at all for training in trauma. When I was at UBC, I did my PhD there. And so I created my own, and then when I came here, since I was faculty, created what I believe is one of the first, not the first graduate level trauma counseling course in Canada that we still run. Now it's a little bit more common practice. A recent change to our own program for graduate counselors is that now the Tri-Phasic model is the standard advanced theory that they're being trained in. Because for those of you who know, when you work in human services, you have traumatized patients. Anybody here have a practice with not a single traumatized person? Yes. Same thing for us. There's not a single counselor, psychologist who will ever work without seeing traumatized patients. So we kind of wonder, like, why don't we just teach that as the way to start looking through client lenses? I am a registered psychologist. I did have a private practice downtown on Amelia Street for about 10 years, seeing military and civilian clients. I was the founder of the Veterans Transition Program, still am. It's a 10-day residential program split into 3 different phases. We've been delivering it across the country, Halifax, Canada, Halifax, Ontario, as opposed to Halifax, United States. And I am the former National Clinical Director. Like most nonprofits, the Veterans Transition Network suffers from a lack of funding, so we couldn't afford a National Clinical Director, so that's why I'm not one anymore. but I'm still a senior clinician there. This is just the Veterans Transition Network website. If you do have clients, and again, referral service, if you have clients who are veterans, we do some serving members, but if you know people who've served, one of the big things that hasn't been talked about today is this idea of group approaches to trauma, particularly with military, which has been my specialization for about 15 or 16 years. Because of the military indoctrination process, where people's individual psychology is basically broken down and reconstituted as a member of a group, my feeling is that if you're not doing group therapy with military people, you're not doing good enough. However, doing group therapy with military people, while easy to start, can get away from you, so you have to be really good at it. Because they're so good in groups. Like they just come together instantly, and they will just take the group away from you if you don't do something about it. So just as a little pat on our own back at the Veterans Transition Network, completion rates for military people in group programs are not great. 65% completion rate, sometimes as low as 45% completion rates. We have about a 95% completion rate for 10 days of residential treatment, which is 100 hours of treatment. And that's split into multiple weekends separated by weeks of break. So we don't just cram them all in 10 days and say, yes, we did it, and sort of lock the doors. They come, they go away, and they come back, they go away again, and they come back for the last one. I don't know if it was Joan who said it, somebody said it. Treatment studies are fine in terms of treatments, but treatments are not independent of the practitioners who deliver them, as you all know. How you do it, and to the extent that you know how to work with the culture that you're working with, will dictate how effective the therapy is. You can't divorce the therapist from the treatment itself. So, a little bit there. Typically when I present on trauma, I do talk about how I got into this. It was actually 20 years ago in December that I was stabbed. And it was in Vancouver. I had moved from Ontario. My now wife and I moved out in a U-Haul van, and I, not knowing any better, broke the cardinal rule about domestic disputes because it sounded like somebody was being murdered, and I got involved. The reason I talk about it is partly because in terms of the social stigma, we're looking now, Dr. Ruth Leanius at the University of Western Ontario is looking largely at PTSD, not as an anxiety disorder, not as a disorder of dissociation, but a shame-based disorder. And treating PTSD as though the foundation is shame, not anything else. And that was a lot of what I went through in not telling people because I thought it was embarrassing. And then somewhere along the lines of my treatment, I thought, wait a second, I didn't stab anybody. Why the hell am I embarrassed? Well, again, that shame of being overwhelmed, of almost dying, being cut open, that kind of stuff, sticks with people. So if you think about this for patients who have it, shame is a really central organizing principle when you're working with them. And it certainly was for me. So it's 20 years ago in December. I'm pretty good, but what I'll sort of talk about is that you don't ever recover from trauma fully, in the sense that you never can uncrack an egg. That's my personal experience. And when I talk to people who survive, you are fundamentally different. But you can make omelets. And sometimes omelets are just better than eating a raw egg anyways, aren't they? Simple versus complex trauma. I'm gonna go quickly because we've been sitting here for a while and it's after dinner, and that way I can keep you awake. For me, and a bit of this was talked about before, you can think about trauma as an intersection, I think, of three kind of axes, if you will. A single incident versus multiple traumas, and Diane spoke to this already, that obviously the more trauma, the cumulative nature of it, the worse it's going to be. And also what I would call the difference between circumstantial and relational trauma. Circumstantial trauma is a car T-boned me at the intersection, just out of nowhere, or the earth opened up and swallowed my grandparents in Mexico. Like, nobody's fault necessarily, but highly traumatizing, versus relational trauma. Relational trauma, and again, a circumstantial trauma is like a person I treated downtown Seattle for the first time. They went on a trip by themselves and randomly attacked. That's not relational trauma, that's circumstantial. So it's not just a personal. The relational thing is you know the person. And as we know, most sexual assaults perpetrated by people who are known to the person who experiences it. And then finally, traumas that occur in childhood and then out through adulthood. So if you think about this, we can guess that multiple traumas are worse than single incident traumas. Typically, relational traumas, far worse and far more damaging than circumstantial traumas. And of course, traumas that occur throughout childhood to adulthood, far harder to deal with than traumas that are just single adult incident traumas. As a practitioner, so for people in your offices, you probably already know this. And you probably already know this because For people who have long-standing developmental traumas, those are the people who start as a 5 or 10-minute conversation, oftentimes, and end up as an hour and a half or 2-hour thing at the end of the day when you really do have to go to the PTA meeting and meet your teacher, your son's or daughter's teacher, and you're still dealing with what seems like just this bleeding of information or just dysregulation. So for me, it's very, very practical in this idea of understanding what are you dealing with. And if you don't know your patient's background, you might think you're dealing with one thing when really you actually might just be dealing with dysregulation, the fact that somebody's been in relational trauma. Because the big thing about relational developmental trauma is that you are in relationship with your patient. Therefore, if they've had relational trauma, you could be a problem for them, even as you try to help them. And you could also be the best thing for them in terms of a relationship that's not like other ones. So multiple relational traumas, especially developmentally, can really cause significant challenges in terms of patient self-regulation. I'm going to talk about what I mean by self-regulation and interpersonal attachment, which was mentioned. For people who don't have secure attachment in childhood, they typically have a lot of self-dysregulation, and they typically don't relate well to others. And for you, in terms of patient management, how many people here can identify in their own practices patients that are like this, that you know they've got lots of developmental trauma, and they're hard to manage sometimes? Not always. Again, you don't want to be too predeterministic about this, but it can be a challenge. Somebody a while ago started looking at this notion of borderline personality disorder, the one thing that everybody kind of goes, ooh. If you think about, and someone was, I can't remember the name of the person who it was, someplace in Surrey, was talking about this notion of early childhood developmental trauma disorder. I think, and don't quote me on this, about 80% of people with borderline personality disorder endorse some sort of childhood sexual abuse or neglect or physical abuse. So if you think about that, is it borderline personality disorder, or is it just somebody who's been really badly traumatized with really terrible attachment, showing really understandable signs of relating? Again, we have to do more research to say for sure, but you can probably guess where I'm hedging my guesses on that one. Okay, if I'm going too fast, unfortunately, I have to keep going because we're a little bit behind, and I don't want anybody to have to worry about not getting somewhere after this. Screening for traumatic events, one of the simplest tools I found, and this is from the clinician-administered PTSD scale, the CAPS, which the National Center for PTSD in Boston says is the gold standard. So if you want to give a really clear diagnosis, and particularly if you have to use the CAPS according to them. It's not the only way to diagnose, but if you're dealing with insurance companies, it's one of those indefensible ones. If you do it right, it will really help your patients. And they have something called the life events checklist, which the link for the current life events checklist will be here. So if you get this presentation, you can click on it. What I wanted to share with you is just a little bit of an adaptation that I made to it, just for my own thing, which is called the developmental life events checklist. So the stuff on the left here, that's just your typical life events checklist. It's not stuff that I've come up with. It's straight out of the CAPS. I'm a big fan of it. But I just added and formatted and worked my way through how to figure out how to do this in, I don't even remember what it was, Excel or something, when it happened. Because as a quick once over, if you have endorsement on multiple ones of these events and you can see the age that they are, you can start to guess some of the things that the person's going to maybe struggle with. Lots of traumas that happen at very early ages, I would put at least $5 on the fact that person's got trouble in their relationships. I would guess probably a good portion of those people will have suicidal ideation or depression at some point. You know, all the stuff that we know from this. If you have one trauma that happened after the age of 15 or 16, you're not going to spend a lot of time with that person necessarily on the trauma. Those people, especially with very effective treatments like EMDR, again, National Center for PTSD, EMDR is a very effective treatment. The thing is, though, that when I'm going to talk about the Tri-Phasic model, EMDR in and of itself is not a trauma treatment.
What is it?
Eye movement, desensitization, and reprocessing. It's unfortunately a little bit anachronistic terminology because you don't need to move your eyes around and people think it's hypnosis. It's not. It is an effective treatment, but it has to be embedded in what we would consider the gold standard model of trauma treatment, which is the Tri-Phasic approach. They got into some trouble with EMDR in the early days because they just started doing it with everybody without a trauma-informed perspective. So again, the treatment itself has to be in the hands of a trauma-informed clinician for it to be effective. So this is available to you. Again, I don't claim any copyright to the left-hand side of it. It's freely available through Life Events Checklist. And I don't care about, you can use this, print 10 million copies and give them to to your patients if you want. Just know that by going through this events checklist, this could really trigger people who have a lot of trauma. And you have to inform that. The top line here that I added in, which is not part of the original one, says, I'm going to ask you about potentially disturbing events in your life, and going through this may cause some distress. Again, no surprises. These questions are important for planning how we'll work together, and we can stop at any time if you'd like to take a break. Again, how you use the tool from a trauma-informed perspective is far more important than just saying, here, take this home. If they're going to take it home, tell them, you could get triggered by doing this, so let's talk about it. If you find yourself getting really upset, stop, put it away, come back, we can talk about it. This is if you're wanting to scream. It's a very simple tool and I think very effective. Moving into what I've been alluding to, this Tri-Phasic model. For those of us in the trauma field, this just is. It's like the water to fish. This is how you work for trauma. If you're not doing things according to the Tri-Phasic model, we all kind of raise our eyebrows and say, really? What model are you using? Judith Herman really was the first one to kind of bring it all together and synthesize it. These are just some references for yourself in all of your spare time. You know, those down moments, you know, over lunch, when there's no patience. This is the kind of stuff you can pick up, and I'm obviously being facetious because I know none of you have any downtime. But if you want to read some things, Trauma and Recovery, I recommend to any trauma counselor. If you don't read that, you're missing a piece. Breer and Scott's Principles of Trauma Therapy, very updated, DSM-5, second edition is very good. Baranowski and Gentry, Trauma Practice, very, very clear tools for self-regulation, what I'll get into. Some of them that have no contraindications you can do in your office. So really effective one. And then for patients, if you're looking for resources for patients who are traumatized, Restoring Hope and Trust, excellent. It's got the little stick figure clip art characters that we used to use in the 90s. But it's very accessible information, and just I give it to anybody who's dealing with trauma. It's not going to traumatize them. It's not going to. There's no contraindications to them having it, and it'll really help them understand what's going on for themselves. So those are a few resources for you. Tri-Phasic model. Phase 1 is safety and stabilization. Phase 2 used to be called remembrance and mourning, and now oftentimes it's referred to as working through the trauma. And phase 3 is reconnection. I'll talk a little bit mostly about phase 1 tools that you can use as practitioners. A lot of the phase 1 tools, there's no contraindications for. You don't have to be a trained psychologist to do them. They're prescription-free, portable, and people can learn them in your office in 10 minutes. So if you're looking for something to do with a traumatized patient, there's a few things you could use. Safety and stabilization is a big deal. I don't tend to think about these as discrete stages. It's more of that kind of circular staircase that keeps going. The idea here is safe enough to do some work. And whatever that work is, if it's not safe enough, you have to go back and get a little bit safer to do some more work. And if it's not quite safe, you have to go back and get a little more safe to do a little bit more work. There's no such thing as someone being safe and then starting trauma work. It just doesn't happen. Paradoxically, the safer people start to feel, the more they start processing their trauma. So for a lot of junior therapists who think, well, I'm going to spend 5 years doing safety and stabilization, you won't be able to stop the stem the flow of traumatic memories that start to come up. Because as they get more resourced, they'll start naturally processing that stuff. Remembrance and mourning is the thing typically in Hollywood you see where the person, you know, gets into, you know, they break down in tears and they finally tell their story and credits roll and everybody's happy. Yeah, it doesn't happen that way. Typically telling your story is not that helpful if it's not done right. And then reconnection. Most people live traumatized lifestyles. They develop traumatized relationships with family, with friends. And as they start to get better, one of the first things to go are traumatized relationships. And it's one of the hardest things because it's a disconnection from people who they probably shouldn't be related to anymore because they've related to them as traumatized, oftentimes people without great boundaries, oftentimes for people who have trouble regulating their emotions. And as they start to learn that, they'll lose a lot of relationships. So I give you this, that if you know of one of your patients who's actually doing active trauma therapy, just having this is like where are you at with your psychologist? Like, are you still doing kind of safety stabilization stuff? Have you gotten into dealing with some of the harder stuff? You know, or are they really through the hard stuff and now they're just trying to figure out how to make friends? In the research I've done with veterans, something that almost all the veterans that I looked at endorsed was troublemaking friendships. And we look at the research on friendships, people who don't have friends get sicker, they die earlier, and they don't do well in their careers. Even though it's a small sort of thing to think about, friendship is a huge deal, and reconnecting once you've healed is not always that easy, especially as adults. So a few things to think about there. So what does it mean to be safe? This is my stuff now, adapted from some of the things that I've worked with integral theory. I look at it in terms of 5 levels of safety for each of your patients. And there's at least 5, there may be more than this. There's physical safety, emotional safety, cognitive safety, relational and spiritual safety. For me, you need to address all of these in terms of looking at it. How do you assess it? Well, you could just ask the person. One of the tools that I have that you're free to use, and I won't go through this whole thing, this is called the levels of safety exercise. Again, this is like a great tool to sit down, either ask your patients to do it and bring it in if you want to talk about it. There's no real contraindications to this. This will give them real insight for themselves as to what they're dealing with, especially if they're thinking about going for trauma therapy. It'll also give you a big indication of where some problems are going to arise. Basically, each of these scales is scaled sort of on 10 points, where I have no physical safety, I have 100% physical safety. I look out for those ones because I don't know anybody who has 100% physical safety. If you drive a car, you're at least at 95, right? Emotional safety. These are sensitizing questions. Again, they're not necessarily meant to be answered, but they could. And you're asking people to rate each of these levels. This will give you a snapshot of their perceived level of safety in their lives across these multiple levels. These are developmental level. As we know, you all know as physicians, babies start first as bodies. There's no real emotion. You know, there's attachment cries and those kinds of things. Then we develop emotions on top of our bodies. Then we get more complex cognitive thinking on top of that, and then we start to relate to people, and then oftentimes people have spiritual connections to community, that kind of thing. So it's all theoretically derived based on some other things, which I won't go into. Once you get the person to rate each of these, then I have what's called a safety map. And basically it's just translating the 10-point scale onto this as a visual. I'm a visual learner, so I use lots of images. If it doesn't work for you, then just use the other, the point scale. But basically each of these circles has 10 little pie sections. And once they've filled it in, starting in the middle with physical safety and moving your way out, when the person fills it in, and they can do this for themselves, and it's amazing what little insights people can have when they see this stuff, is that this is what it can look like. So given the labels there, where is the person struggling in terms of safety? Right there. Like, it's a very simple visual. They're not safe in their relationship. They're just not. There's holes there. For me, I'm looking for something with almost 0 holes. If I'm talking about somebody who's really well-resourced, there's almost no holes here. For somebody who's really, but what else do you notice about this? What strikes you about this just simple visual? Where's the most safety? Yeah, so think about that patient who may have trouble in their relationships, but their relationship to God, the universe, to nature, whatever it is rock solid, unshaken, absolutely a resource for them. What a nice thing for them to know that they're not just a bag of hammers, right? They're not just completely destroyed. They're not just anything. They're multidimensional people. So, and again, if you look at this, somebody comes in with one section filled in of each of these circles, you got a lot of work to do before you get going on any of the trauma work. And that's the thing with the phase model, people have to have levels of safety adequate to where they're going. So stabilization, really what we're talking about stabilization is this notion of self-regulation, which I'll get to, but there's another idea in what we do in terms of resources, knowing patient resources, what they have. A resource is basically anything you can rely upon to be there for you in times of need. So it's very, very simple thinking about that. Again, you can use this, you can print it off. If you want a nice Word document copy, email me afterwards. I'll send it all to you if you want to look at it for yourself. I won't go through it. But basically, their resources can be divided into 4 quadrants. The upper left quadrant is anything internal to them that they feel is a resource. It could be their spiritual beliefs, the way they think about it, their sense of self. I know I'm a good person, but I'm kind of screwed up. Anything on the top right is any physical resources they possess for themselves. Well, I'm still got my health. I work out still. I can go for a walk every day. Whatever resources they feel they can reliably draw. I sleep okay. Typically, people with trauma, as we know, they don't sleep okay. They usually sleep very poorly. So looking at this, again, when patients go through this, clients do, they get a good picture for where the work needs to go. Bottom left is relational safety, relational resources. Who in your life are the people you can most rely upon? Who do you know will be there no matter what? Oftentimes, these are the most challenging ones because these are not easy to find or to create. And the bottom right one we don't often think about is people's physical environment. Even if people have nothing in the other 3 quadrants, sometimes they have a room that they can lock their door, light a candle, cozy up underneath a blanket and shut the world out. That's a resource. Even though it might be sad to think about the person doing that, it's a resource. If they can comfort themselves in their physical environment in any way, we live in one of the most beautiful places in the world, right? Sometimes nature is a resource. Sometimes nature is the source of it. I went whale watching one time in December. Please don't ever do that. We hit an ebb or a flow tide. I don't even know which one it was because I'm not a nautical person. And we had to tack for 45 minutes into 6 to 10 foot swell just to get back. I hurt my back. I had blisters on my hands. And being a trauma therapist, I recognized my anxiety responses following that. When the weather was up and the white caps were there, I got anxiety. I was like, I'm never going in the water again. So, okay, Tim, just calm down. Go down to the beach. Desensitize yourself. It actually helps sometimes when you're a trauma therapist. So, anyways, and I still remember it, right? I mean, that was a good hour-long tack where we just, anyways, I don't need to go there. Moving on. Isn't that a nice picture? And again, I'm a visual learner, so I try to put these things in here. I want to introduce you to something called the window of tolerance, which I think could really help you in your practice if you're thinking about people who have trauma in their backgrounds. So this is Pat Ogden's work. The window of tolerance basically sets out this metaphor that there's an ideal level of activation that telling your traumatic story will be helpful. And that is neither parasympathetic, what they call hypoarousal, which is not enough activation, not enough emotional attunement to what's going on. You'll see people, typically what you'll see is people telling their story with incredibly gory, oftentimes detail, with zero affect. Anybody seen this? You've seen that? That's hypoarousal. They could tell that story 1,000 times, they will not get better. It will not change anything. And this is a typical example here of the World War II vets, whose families will tell you, I can tell you that story backwards and forwards with all the detail because it's the same story. He's told it 1,000 times, but it doesn't go anywhere because if you're not engaged enough with it, it does nothing. So think about this when you're thinking now, when we get to that point of when people start talking about their trauma, what do you do about it? The other side of it is sympathetic hyperarousal. These are the people who can't hardly speak. They start to speak and they start to shake. How many people have seen this in your office? They start to say something, they can't even form words. Their bodies are literally shaking in front of you. Carrying on from that point doesn't do any good. You may as well just stop right there. People have to be in a tolerable enough level of arousal for when they tell their story to have any use whatsoever. And I will stop people from speaking if they're either hypo or hyper because it's a waste of time. Oftentimes, if they're hyper aroused, they also may dissociate, where they'll tell you lots of stuff through their tears and shaking, they won't remember it. So think about this. You go to your doctor, you tell them a story, you go home, and you can't remember the hour during the session or the hour after the session. And your doctor goes, oh, that was a great session. I learned a lot about that patient's history, and wow, they told me this incredible story. I'm going to follow up with them. They don't remember. I've been in sessions where people have come back from a very severely dissociated state. I think about one female soldier I worked with, and she was so upset because the last half hour she didn't remember a thing that we had talked about. So again, not helpful in terms of processing trauma. So self-regulation, really, these are tools to help people stay within the window. Okay. First of all, what is it? For me, this is just my working definition. It may have come from somewhere that I just pulled out of my brains, but I don't know, I can't remember. The ability for patients to monitor, engage with, and to some extent control their behaviors, emotions, and cognitions without becoming overwhelmed by or dissociated from their experience. So how many people in your practice, or how many people here have patients who have problems with self-regulation? How many people here have no patients or who have problems with self-regulation? Good. Because we wouldn't have believed you anyways, right? We would have known you were lying. That to me is the hallmark of what we do as individuals when you're in a non-traumatized or what we call pathological state. You can manage your behaviors, you can manage your emotions, you can manage the way you think about it. You do okay. Yes, sometimes you're upset, sometimes you're not. A lack of self-regulation is you cannot, despite your best efforts. So if you can teach your patients some of these basic tools, they can remain present to their experience and remain grounded. You know, there's these sort of terminology that we use in the trauma field, grounded. Grounded literally means in the room. And there are people who, if you've had dissociative clients, they will tell you, I wasn't even in the room for the last 10 minutes. or I noticed I was floating above us, or you feel like you're way down at the end of a long hallway and your voice doesn't really sound like it's you anymore, and I don't even feel like I'm here. Those are the typical dissociative experiences. Self-regulation tools to help people stay more present, because again, if you're going to do any work with people, it kind of goes without saying, but they kind of have to be in the room. Not just physically. If they're psychologically and emotionally not in the room, nothing's happening, okay? They can remain engaged without getting overwhelmed. Again, I'm not afraid of intense emotion. I just have to make sure it's tolerable and the person isn't going hyper. So, you know, in the group work that we do with the veterans, sometimes there's intense expressions of emotion, which some people get scared of. And for me, it's always, are you grounded? Do you know where you are? Do you know what you're doing? And is it tolerable? As long as it's tolerable, it's okay. It's when it gets intolerable or scary that I can't control it, that's when you need to stop. These tools will also help them from getting overwhelmed emotionally and cognitively, because sometimes the thoughts just start to roll and they start to roll and they start to roll and the people feel like they can't stop them. It gets really upsetting. And then if they're going to do trauma work, learning some of these things can help them really get into doing some of that harder stuff later. So before getting into some of the specific tools, just in terms of addictions, most of us, I think, especially in the West Coast, are familiar with Gabor Mate's work around addictions, Realm of Hungry Ghosts, Body Says No, all that kind of stuff. So this is taken off of his website. And like him or hate him, he's doing some very interesting work around addictions. And for me, the connection between addictions and trauma is really striking. So in the case of Priscilla, Priscilla's one of the, he's talking about the war on drugs and how useless and how immoral at one level it is and how unethical it is. Priscilla is one of the enemy in the war on drugs. She sells cocaine to support her own habit, a dependence from which no calamity has been able to shake her loose. Not the loss of her child, not HIV, not multiple illnesses, not brutal beatings at the hands of male, quote, clients. She became one of the enemy at 15 when, after many years of sexual abuse by her grandfather and uncle, her mother injected her with heroin and sold her into prostitution. So people talked about, like, what's the comorbidity of addictions and trauma? You know, we can debate the facts around that. Just when people have it, it's really problematic. This is just a quote again from that website that basically a study published in the Journal of the American Medical Association concluded that a history of childhood abuse per se is related to increased nervous and hormonal stress reactivity, which is further enhanced when additional trauma is experienced in adulthood. The point is that the addict is re-traumatized over and over again by ostracism, harassment, dire poverty, disease, the frantic hunt for a source of the substance of dependence, the violence of the underground drug world, and harsh chastisement at the hands of the law. All consequences of the war on drugs. So I think we all know this as kind of socially responsible people, that it's problematic, but oftentimes this stuff starts out as a self-regulation tool. And that's what's really hard about it. If you look at through this notion of self-regulation, remember, the ability to regulate your state, addiction and substance use really makes a lot of sense through the trauma lens. So if you recall, the number 3 point I made is self-regulation tools help people remove themselves from overwhelming emotional and or cognitive states. Well, what does getting high do except this? That's the hard part, is that it works, but then it doesn't work. You know, someone asked about pot. Sure, a lot of the people that I've worked with in the past have managed, and even have medical marijuana to manage their PTSD symptoms. But the notion of having to be going to get the pot, going down to Carroll or Pigeon Square in Maine and Hastings to go to a dealer, to not get beat up because you look like someone who they would beat up, not get rolled once you get your dope fix. All those things that go around with that kind of stuff, even if the pot works, are problematic. So obviously they can at least initially assist patients in regulating their emotional discomfort. In terms of trauma treatment, people talk about, like, do you do abstinence or do you do harm reduction? What do you do? What I can tell you confidently is that with trauma work, things get worse before it gets better. And if the person's using substances to self-regulate, if they're using it for self-soothing, for sort of managing those symptoms, and they start getting into their trauma story, basically you need to make sure they have in place some way else for them to self-regulate. Because otherwise the risk is just too high. It just makes so much sense. That as I start to get into my traumatic memories and all that stuff starts flooding up and all the emotions start flooding up, the easiest and quickest way for me to get that stuff out is to go use again. But it's also one of the most detrimental ways for managing it. I want to speak just a little bit to, SSRIs. I started looking at this stuff about 10 or 12 years ago. Nothing's changed, folks. in the time. I was really curious about Diane's presentation because I saw it beforehand. I said, oh, I want to see, like, what's the new treatment? Like, what are we doing now? It's the same stuff. And it is helpful. For me, it's helpful for people to access therapy. That's why I use it. Large doses, a lot of the veterans I see, 6, 7, 8, 9. General Dallaire, when we hosted him here at UBC, he said he was on 12 prescription medications for his PTSD. The last time I met him, he was the host of our coin ceremony for the Veterans Transition Network, where people get a coin for having gone through the program. He came. His recovery was that he was on 8. And it's not confidential. It's not like he told me, I'm not his client or anything like that. He was very open about it. Think about the drug interaction effects of 8 different drugs. 1 to go to sleep, 1 to get up, 1 to manage it. And people are prescribing, I think honestly for good reasons. They're struggling. They want to help. They want to try and adjust the meds. They want to do something that can help. But what I've seen a lot of the veterans that I deal with are way over medicated. They've got tons of stuff. They don't even know why they're taking it. And the dosage, you just don't even want to know. You probably already do know. The dosages that they get into, who knows if that sort of treatment fidelity is there. It is very helpful though, because if you can't sit in a therapist's office and you need some SSRIs to do that, then you need to do that. Because otherwise you won't be able to sit in a therapist's office. It's just too much. So, I've already said this. Just a word about telling the traumatic story, again, getting very pragmatic about this, if people start talking. Anybody recognize this place?
Matterhorn.
Mount Everest. Anybody ever been there? No. Okay, so these are my resident experts. I read Into Thin Air, the John Krakauer disaster book, and I've always remembered that, because you know what John Krakauer taught me is that I can get to the top of Mount Everest. And I was like, that is great. I have no interest, but if I did, like I actually felt pretty proud. I was like, all right, I can get to the top. You know what John Krakauer also taught me? I'll die there. Because anybody can get to the top if they're in half decent shape. It's that if you do it the wrong way, you will be one of the bodies that stays up there, because guess what, folks? They can't carry you down. The blood oxygen content is so low they can barely get themselves down if they do it right. This is a great metaphor for me if you turn on its head about trauma. You know how easy it is to get someone talking about trauma? It's so easy. Everyone thinks like, oh, the big movie, right? It takes the whole movie before someone talks about it. It's like, it's not true. Like, if you just do it right, you can get people into their trauma quick and fast, especially if they're in crisis. You can take them there in a heartbeat, but you will not get them back out of it safely. So for me, I always think about this thing is that if we're going to get into it, it's my responsibility to get you down off the mountain without you being worse off than when you came in. That's the nature of trauma. That's been my experience, because once the processing starts, if the person doesn't have the tools to deal with it, it won't stop. And who knows what the rest of their week or the 2 weeks or the month before you see them again is going to be like. So for me, if you're thinking about patients, if you have patients who come in and they start storytelling, they start talking about it, I really encourage you to stop them. But to say this in some form of your own words, telling your story is really important. The truth is, though, simply telling your story will not do anything for you. It's not going to help you. In fact, it might make it worse. So I'm going to ask you to stop right now. It's not because I can't hear it. It's not because I don't want to hear it. And these are the words I use to people. And I'm a trauma therapist, so my job is to listen. But I will stop people and they will get frustrated with me. Well, I've spent all this time. I want to tell you. I know you do. But you have to understand that how you tell the story will indicate and dictate whether or not you get better. And I'm not interested in you telling a story that's going to make you worse. Or at the very least, waste both of our time because you told it in a hypo-aroused state and you gave me all the gory details and you felt nothing, because nothing's going to happen except I might have the details, which I don't actually need as a trauma therapist that much these days. So really encourage you to consider just asking people to pause, but give them the reason. This is the thing as a psychologist. Just give people the reason why. If you just say, we're not going to talk about that, what else do you want to talk about? They're just going to get mad. They're going to get defensive. They're going to think you don't care when you really do. Give them that little piece of information. It's how you tell it. So if they want to do it, get in touch with people who know how to help them tell it. Sexual assault center, men's trauma therapists throughout town, that kind of thing. This is a quiz for people who might know this. So this is a word about.
Trigger.
Hey, all right. This is trigger is a stuffed dead horse. And whose horse is it? It's Roy Rogers' horse. So Trigger got stuffed, everybody. And why do I put this here? Because it's almost 9 o'clock at night. And if you remember nothing about this, you will remember this really strange picture of Trigger, the horse. Triggers are both internal or external cues that really prompt a traumatic response to a typically non-traumatic stimulus. I say internal and external cues because it could be the smell of your perfume, the glasses you're wearing, those are external cues, the sound of a horn, it could be the diesel fumes from the truck that just went by outside your office. I think with the military people, the APCs, Armored Personnel Carriers, they were all diesel runs, so people were triggered constantly by diesel fumes. Those are external cues. Internal cues are things as simple as a sensation in my chest. Right before the Taliban killed my partner, I got this feeling in my chest that something was wrong. And so that internal cue can trigger a full-blown traumatic response, and you don't even know why, and they don't know why. And it could happen in your office. Telling someone's trauma story in an unregulated way can trigger the hell out of people. This is why I'd say, like, you're just not going to feel that great after this, so why bother? Let's not do this. But the good part, I always like to give the hope of the, there's always the nasty stuff with trauma. The hope is if people can learn their own triggers, they can start to take control. If they can start to just look at what is it and logging their triggers. If you want to give patients who are dealing with some stuff to do at home, start to notice what triggers you. Is it the news? Is it a particular smell? Is it something that you've thought about? Is it pictures of those things that happen? Really easy to do. Coming to see a physician, unfortunately, could be very triggering for people because relationally, there's my 5 minutes, relationally, you have power. And for people who've experienced developmental trauma, you're dangerous. So am I. So we're all in it together. We're also potentially very helpful, but you're dangerous because you have power over me and I have to come for help. So if you just understand that simple fact as well, by the nature of your position, you can trigger people with developmental trauma and tread lightly on that. These are some of the techniques I won't go into right now. I said to Linda earlier, this is like a very compacted version of little tidbits. These things are actually easy to train. If a group of 12 people would want to get together and train this kind of stuff, call me and we can talk how we might do that. They're simple to learn. Again, no contraindications, prescription-free and portable. The olfactory anchor one is interesting. Okay, here's where you get your prize. I actually don't have a prize, so I don't even want to be disappointed. Does anybody know or anyone want to take a guess what CVC stands for? I know I made it too hard. There's like item consistency or item strength. Like this is one of those ones where nobody in the class gets it right. That was also just a way to keep you somewhat engaged and, as the food's digesting and all that kind of stuff. So I have this here because you've got the cerebral cortex and then the lizard brain, which is when I speak to non-medical people, I call it the lizard brain. For me, as a mantra for practitioners, choice, voice, control. If you look at your practice through this idea of choice, voice, control, anytime you can give a patient a choice about what's going to happen to them, give it to them. It'll help you. They won't be as stressed. They'll trust you more. They'll feel more in control. Listen to their voice, which I think for most family physicians, they get it. Like just listen to how they're doing, ask them how they're doing. And then control. At any stage in the game that you can relinquish control over anything that's happening to them in your office, do it. It will pay dividends. Because oftentimes physicians, and I have great compassion, you do much harder work than I do because you have to deal with real death. And we do with suicide, but you're dealing with very complex systems. So sometimes you can't give up control. But if you look at your practice and examine it through this lens, really ask yourself, when could I, with this particular person, give them a bit more choice? When could I ask them a bit more about and how could I give some control over? Not the timing of the session, though. You don't want to give that one over. So last thing, and this is just, I'll just sort of give you some tidbits for me. Your office, because it's potentially triggering an environment, ask yourself, where do you situate yourself? If you sit yourself between the patient and the door, you're going to trigger the hell out of anybody who's been trapped or abused or assaulted and couldn't get out of it. Now, there are some very real considerations, especially if you're working with populations who might be prone to violence, that you don't want to be the person on the inside. I talk about this with the docs. But you might want to consider if you both had equal access to the door, that might be better because people get triggered and not even know it. When you block their access to the door, things like that. Your waiting room areas, in terms of shame, going back to this notion of trauma as a shame-based disorder, people having to look other people in the face when they're coming in after a sexual assault and they have PTSD or they're developmentally traumatized, sitting in their office looking at other people. I know it's hard, but these are the things we don't oftentimes think about. Anyways, I won't spend too much. I have a no surprises policy. I don't ever surprise anybody if I can help it. So think about your practice. How many times does your patient come in and they get surprised by the information you share with them, or a procedure that has to happen, or a result of a test, try your best if you can to give them a heads up. So just on that, I try to tell people ahead of time, here's what's going to happen, here's why I want to do it, but this is what we're going to do. So at the beginning of a thing, you might say, here's what's going to happen today. I want to talk to you about this. I want to hear what you're bringing because you told my secretary it was the gout or whatever. And then I want to ask you a couple questions. So let's start with that. Again, that gives person a heads up. It's not going to surprise them. Again, these are things that you just have to apply through your own lens, through your own practice to see what makes sense. Predictability and control. If trauma does nothing else, it strips somebody of their individual sense of control and predictability in their life. Any chance you have to give them some predictability over what's going to happen, again, it would just pay off in dividends. So closing thoughts, last but not least, so obviously traumatic events are ubiquitous, but not everybody's traumatized as we get. Post-traumatic stress responses are understandable, yet problematic responses. I also want to just briefly mention about PTSD. It's not a dichotomous variable. There's a whole continuum of post-traumatic stress reactions, and so if you only focus on the diagnosis of PTSD, Shalev did some research before that said people who don't get diagnosed on the DSM-4 criteria usually don't have the avoidance criteria. They still got hypervigilance, re-experiencing all that kind of stuff. So considering it as a continuum. And then for me, healing is never about cure with PTSD. It's about growth, and sometimes growth through limitations or even inspired by the limitations that you have. And for me, that's kind of how I think about it. Sometimes if I get stressed out, I still have symptoms come up, but then I just manage it and I just keep going on. If I don't manage it, I get into trouble. Whew. We're done. Thank you. So I see the mic is getting turned on, which means we must have some time for questions. Yes, please.
What is your email for those tricks you were saying for self-regulation?
tblack@uvic.ca, or if you just Google Tim Black, University of Victoria, you'll find me in several different ways.
Thank you. And just one more quick question. I have a new practice and a new patient who's had a pretty severe childhood trauma that I found out through old records that came to me. She has not disclosed this to me, and she has a recent addictions history and a lot of issues. Is there any use to letting her know that I already know what she's been through, so she knows that I don't have to bring it up? Or would that make her feel more vulnerable? Like, I don't even know how to approach this with her without triggering her, like you're saying.
Yeah, and again, you try to avoid triggers, but sometimes it's just unavoidable. I mean, I'm a hell of a trigger because I'm a trauma therapist, so people coming into my office are triggered already. Like, just seeing my face is going to trigger the hell out of them. So would she know that you have all of her records? And would she know that that event was in her records?
I think I could let her know that these records have come to me maybe as a starting point, because I think she knows that as her new family doctor I would be receiving those. I don't think that would be shocking. So maybe I'd start with that. Yeah, like I think if she knows you have the records, it may be one of those things where she's like, oh God, when is she going to bring it up? When is she going to bring it up? Oh, I know it's in the other doctor had it in the file. She's my new doctor. And so letting her off the hook, the way I would say is, I do have your whole medical file with all the stuff that your previous doctor knew. If you want to talk about any of that stuff that happened, in your other file, anytime, just bring it up anytime. I'm more than happy to talk with you about it. Then it's like, okay, I know she knows, we've talked about it, and I get to choose whether or not I bring it up, for sure. That's my recommendation. Yes, please.
You told us that this Tri-Phasic model is very popular amongst all the psychologists dealing with trauma. Yeah. But you really haven't told us what the level of evidence is like for the effectiveness of it. And I wondered if you could briefly, I know we're at the end already, but we don't have time.
No, it's okay. I think the tricky thing around this is that most of the outcome studies are on particular interventions. So if you think about the Tri-Phasic model as sort of the groundwork for even using an intervention. So EMDR, for example, is considered a very effective intervention for PTSD, but if you use EMDR and you don't have the person stabilized or resourced, you can actually do a lot of harm. So those outcome studies are using safety and stabilization and this idea that people need to be able to self-regulate through the process. Most of them prolonged exposure, all the evidence for the really robust therapies. If you talk to the therapist, it's not a treatment per se, if you think about it that way. It's an overarching model of how to get the person prepared for treatment. Almost like you would do if someone's gonna have heart surgery, you'd put them on diet. It's like saying, what's the efficacy of diet for the open heart surgery? Well, it certainly does help, and you wouldn't wanna do the heart surgery if the person hadn't changed their diet or exercise. It may not be a perfect metaphor, but I have never seen anybody investigate, because of the ethics of it at this point, doing a non-triphasic approach to trauma, because we kind of already went through that with EMDR where they didn't use a triphasic informed model, and people started decompensating because, again, that whole Mount Everest thing, EMDR can get you into your trauma very quickly in a very unresourced way. So it's an interesting research question, like a very interesting research question. I don't know how you design an ethical study at this point, because it's become common practice that you need to do this or people will get hurt. I don't know if that answers your question, but yeah. Great research question. Any other questions? There's one here.
In the two presentations this evening, we've talked about the various symptoms that are associated with trauma and PTSD, depression, anxiety, relationship issues. I don't think I've heard the word pain any time tonight.
Yeah.
And is that because it is not associated with these symptoms, or because it's so ubiquitous that it just pervades these people who suffer from these conditions?
Yeah, the only pain I could speak to is psychic pain. You know, the psychic pain of not being able to control stuff that comes up, continually trying to get ahead and then getting knocked back down again. Physical pain I've not seen. All I've seen is how pain exacerbates PTSD. So for the people I work with, if they have chronic injuries, if they have chronic pain, it just makes life so much harder. Especially if the pain from the injury is also a result of the trauma. It's funny, in the military world, they differentiate between like somebody who had their leg amputated and somebody who had a trauma. Like, well, how do you unpack that? So I've never seen somebody with PTSD as pain as the presenting symptom that wasn't connected to something else that wasn't about PTSD, because there's lots of people with PTSD who have no physical pain whatsoever, and there's lots of people with PTSD who have physical pain but usually either undiagnosed and they don't know what it's from, or attributable to some injury or some previous thing.
So you see them as two separate issues?
I would see them that if pain is present, it's gonna make recovery from trauma much more difficult and much more problematic, and you're gonna have to manage that pain really well, because that's just, again, that safety, physical safety. Intense physical pain threatens physical safety, which is the foundation. So if you can't manage the physical pain, it's unlikely you're gonna get very far with the trauma. That's not, I don't know, I can't speak to the research on that, but that'd be my clinical guess on that one. Anything else? Joan?
I just wondered if you have time to expand even just a moment on talking about borderline personality disorder and how I think it gets diagnosed or confused sometimes with the continuum of trauma. I just wondering what you meant by that.
Well, I'm just really curious about it. Again, it's more of an empirical question than anything else. But when you see, again, it's hard to develop longitudinal causational studies because typically people who are being sexually abused, their parents are not the kind that are going to opt into studies. You know what I mean? Like they're not at the doctor's going, hey, where do I sign up and how do I fill out forms regularly for my kids? They're usually doing terrible damage and not going to the doctors. So yeah, it's a hard thing. I don't know that we'll ever have a really good empirical study to prove it, but theoretically, I don't know. When I think about treating borderline personality disorder as multiple childhood developmental trauma disorder, I think it just makes far more sense than trying to just. And Marsha Linehan's work with dialectical behavioral therapy really bears this stuff out. You know, she's the leader, and DBT is a very effective treatment for borderline. It's really the treatment of choice for borderline personality disorder, and it's all based on childhood trauma and developmental trauma.
Right. So otherwise, it could be very long-term work. It is often would be very relational with the therapist.
The hard truth of it, Joan, which you would already know, is that for somebody with long-standing developmental trauma, you will not help them much, except in long-term psychotherapy. But that doesn't mean you shouldn't help them. Like, so how many people have the resources to spend 5-10 years in therapy? Almost nobody. But that's really, if you're really talking about getting to some semblance of really good self-regulation, really good ability to sort of monitor oneself, deal with good relationships, form that, you only learn that through relationship. You're not going to learn it through a manualized treatment. It's just not going to happen. Thank you. Thank you very much.
Yeah, thanks. Thank you, Tim, and thank you, everybody.